And since it's a master class, we'll quickly try to assess the knowledge of everybody. The first question is International PCO Guidelines of 2018. They follow which classification? NIH, Androgen Access Society classification or doctrinal classification? You can just tell me whatever is in your mind. Come on, fast. Which is the classification which they apply? A, B or C? C? Everybody C? Great. That's the correct answer. The next question. As per 2018 International Guidelines, ultrasound criteria for diagnosis of PCO are either ovary more than 20 follicles of volume more than 10 cc, 20 follicles in both ovaries with 50 cc volume, or 25 follicles in each ovary with 10 cc volume. A, B or C? A. Perfect. आता मला शिकायची गरजच नाही आहे तुम्हाला सगळं येतं. What is smart approach? It is the approach in PCO infertility treatment. It is the approach for weight reduction in PCO. It is a treatment of PCO done by a smart doctor. That's a smart doctor like you. That's a smart approach. So what is the correct answer? Smart approach? C? C. So correct answer is, for all of us it is C, because all of us we are smart doctors. But the right answer is 2. That is, it is the approach for the weight reduction. The next question. Which is the first line of ovulation induction drug? Clomiphen citrate, letrozole or gonadotropins? B. Letrozole. Perfect. In resistant PCO, laparoscopic ovarian drilling comes as a second line along with gonadotropins, as a third line after gonadotropins, or no more recommended as a treatment of choice? No more recommended. Okay, so we will discuss this. Actually, the correct answer is A. It's a second line of treatment along with gonadotropins. But few people they think that it is C, and they are also right. I'll tell you how and why they are right. The best policy to avoid OHSS in IVF is ghosting, agonist cycle with HCG trigger, or antagonist cycle with agonist trigger and phase of policy. C. A, B, C. It is C. And that is what we are going to learn, because soon you will start IVF center, then you will come to know how to manage a case of IVF and PCO. But the answer is C. Now I will tell you a story of Priya. Priya is a young girl. She is in her late 20s. She did her fellowship in ART and decided to set up a new clinic. She gets classical case of PCO, flash diagnosis, BMI 36, acanthosis nigricans, ovulation, marriage since 5 years, and eager to conceive. Basic investigations done, she starts clomiphen citrate, patient conceives in the first cycle and will pregnancy. Happy end of the story. Now Priya is wondering why her guide says that PCO is difficult to treat. Because Dr. Priya is in her honeymoon period of clinical practice. So what happens in honeymoon period? You get quick results and you are very happy. 5 साल बाद क्या होता है? Dr. Priya is frustrated. PCO, she says, PCO is the most difficult situation and she has again started respecting her guide. So ये है कहानी घर घर की, और तोड़ मोड़ के बोल क्या है? Respect your teachers, respect your guide, because they have experience which you don't have. Now PCO. PCO means anovulation. Anovulation means PCO. And whatever we are doing in the next 30 minutes, we will be following these guidelines by ISHRAE 2018 guidelines, which are now the latest guidelines. ये एक लंबी कहानी है, and it starts with adolescence, and that is why it is said you should catch them young, because you should try to understand what is the meaning of irregular cycles. Try to understand this. This is very important. Irregular cycles are normal in first year. Okay, it is normal. After 1 year, any one cycle of more than 90 days is considered as abnormal. Okay, from 1 to 3 years after menarche, less than 21 days, more than 45 days is considered as abnormal. After 3 years, less than 21 days and more than 35 days is considered as abnormal. What is primary amenorrhea? If at the age of 15 years, no menses, primary amenorrhea. Or 3 years after thyroidectomy, if no menses, it is primary amenorrhea. Clear? So this is very clear. Now, why I say that you should not label. See, a 14-year-old girl may come to you in the OPD and she will say, "Me PCO case hai." Why? Because she is labeled as PCO. Everybody says, "Tula PCO hai, tula PCO hai, tula PCO hai." ती बिचारी label हो जाते PCO जी. Remember, friends, up to 8 years after menarche, do not label a case as case of PCO or call them as multicystic ovaries. What do you have to call them? Multicystic ovaries. And after 8 years, reassess the patient. If still the patient has got irregular cycles, if still she has features of PCOS like acanthosis nigricans or obesity, and if you think that she is a case of PCO after biochemical analysis, then label her as PCO. Otherwise, call them as multicystic ovaries. Okay? These are the guidelines. Before we start, I'll tell you one practical point. Whenever you do ultrasound of a case of PCO, you will find that sometimes the ovaries are very big. They are bigger than the size of the uterus. And not only that, sometimes the uterus is small in size. Why the uterus becomes small in size? It is because of the amenorrhea which the PCO patients have. So, to avoid this, because what will happen if the uterus remains small because of the chronic anovulation, this uterus will have a problem in infertility, and not only that, even that may lead to preterm labor also because of the small size of the uterus. So you should try to achieve at least 6 to 8 cycles in a year. So that should be your aim. Means what you do, after 1 month, suppose the patient does not get periods, you can continue her and ask her to take OC pills, but many girls are not comfortable with everyday OC pills for years together. So what you can do is you can have a simple formula that you can give Trimoludine for 3 to 5 days after 1 month so that she gets withdrawn, and see to it that she gets at least 6 to 8 cycles in a year. That should be your aim, right? So that is the reason why I am saying calcium. Calcium का मतलब क्या है? जल्दी से उनको यूट्रस का साइज छोटा होने के पहले उनको कैच करो so that they do not have problem in future. Whenever you think of PCO guidelines, you should know which classification they are following. And as we have already discussed, they are following Rotterdam classification. But there are many classifications which are there available in the textbooks. And NIH 2012 classification is something which is important. And why it is important? Because this classification, ये बहुत smart लोग हैं. इन्होंने क्या किया? Rotterdam के criteria साथ में ले लिए. And along with that, they have added phenotypes to the classification. And these phenotypes are important because you can actually, now you can make it a habit. Whenever a patient comes to you in OPD, try to classify that patient into various phenotypes. Make it a habit. करके देखो. So phenotype A is a classical PCO, flash diagnosis, overt PCO with obesity, everything. Phenotype B, ultrasound features are normal. Phenotype C, they are ovulating but they are still PCO. And phenotype D are mild PCO where there is ovarian dysfunction and polycystic ovarian morphology, but most of them they are lean and thin PCO. And therefore they don't look like PCO. If you look at them, you will feel that she is absolutely normal. You do her ultrasound, you will find the ovaries are big inside and there is a polycystic ovary. So this is a category of lean and thin PCO. And why I am telling you this? Because you should be able to differentiate between the lean PCO and the obese PCO. The basic difference between the lean and obese PCO is the LH levels. Lean PCO have got high LH levels while obese patients have got low LH levels. Why this is so? ये क्वेश्चन आपको एग्जाम में पूछ सकते हैं. Because leptin resistance and adipokinase inhibits GnRH secretion, hence low LH in obese as compared to lean PCO. So that is the answer to the question why the LH levels are high in lean PCO. Now other findings, androgen excess. The most important thing is androgen excess is what is seen in obese PCO. It is not seen so in lean PCO. All the chronic features like hypertension, diabetes, or endometrial hyperplasia, or endometrial cancer, they are seen more in obese PCO as compared to lean PCO. And even the high insulin levels and insulin resistance is also seen more in obese as compared to lean PCO. But at the same time, remember friends, the insulin levels are high even in lean PCO. Insulin resistance is there even in lean PCO. And that is the reason why you should keep in mind, you may get this question, that why the metformin should not be given in lean PCO. You can and you should give metformin to lean PCO as well. ऐसा कोई जरूरी नहीं कि metformin is a drug for obese PCO. It works very well even in lean PCO because insulin resistance is there even in lean PCO, though it is less as compared to the obese PCO. Try to understand this. Now, there is something called ethnicity, or now the world is small. Soon you will get somebody from other ethnicity coming to Nagpur as well, and therefore you should know that ethnicity the features change. Like Asians, Indians have more severe hirsutism, then they have increased central adiposity, insulin resistance, diabetes, metabolic risk, and acanthosis nigricans. More common in Asians. In East Asians like Japanese, they have low BMI and mild hirsutism. In Africans, they have high BMI and metabolic features. So you will have different features in different areas or ethnicity. Whenever you diagnose PCO, you have to consider three things: clinical hyperandrogenism, biochemical hyperandrogenism, and ultrasound. And clinical hyperandrogenism, you know that there is something called as modified Fuhrman-Galvez score, and you can do this. Try this. Whenever you get a young girl with hirsutism, you keep this modified Fuhrman-Galvez chart with you in the OPD, and you can actually classify her into the mild or severe hirsutism. Similarly, there is something called as blood score for alopecia. I don't know what is that, but it is there. And for acne, there is no scoring system. So these are the scores which you should know as far as the hyperandrogenism is concerned. Then there is a biochemical hyperandrogenism where testosterone levels are high, androgen index is high, and DHEAS and androstenedione levels are also high. Here you should remember few things. One thing you should know is the free androgen index is the most sensitive marker of PCO. Remember friends, free androgen index is the most sensitive marker of PCOS. And if the patient is on OC pills, you should stop OC pills and do biochemical test of PCO after 3 months. So always take history, and if the patient is on OC pills, wait for 3 months and then only do the biochemical testing. These are the things which you should know. Then the ultrasound. Ultrasound is extremely important, and it is the man behind the machine which is more important, because ultrasound सभी कर सकते हैं, लेकिन man behind the machine is important because he is the person or she is the person who will exactly give you the diagnosis of PCOS. So which is the method of ultrasound which is preferable? It is transvaginal sonography. Of course, it is transvaginal sonography which is preferable, but here you should know that if the patient is unmarried or a young girl, you have to do transabdominal sonography. The criteria are with 8 MHz probe, either ovary 20 follicles of 2 to 9 mm with volume more than 10 cc. This is the criteria given by the ASHRAE guidelines. But there is an Androgen Access Society, and they have given the criteria of the follicle number per ovary more than 25. Now why they have said 25 and not 20? Because Androgen Access Society has considered the classification with the machine which has got a very high resolution. So as the resolution of machine is increasing, the change in the definition can be noticed. Because what happens is, this is something which I would like to show you, that there is something called as Sono ADC, and this is a feature of Voluson machine where they get the 3D picture of the ovary, and therefore the follicles in the depth in the 3D can also be measured, and therefore the number is increasing. That is why I said as the machine resolution is increasing, the number is also increasing. We at Omega, we are having 5 USG machines, and we have Voluson E6, Voluson E8 and Voluson S8. All these machines are wonderful machines, and they give you so many features and so many applications that you can very easily count the number of follicles. One more point which is important: whenever an unmarried girl comes to you and you do ultrasound, do not measure the number of follicle on transabdominal sonography. In transabdominal sonography, what is the diagnosis of PCO? The diagnosis of PCO is volume more than 10 cc. That's all. No mention about the number of follicles. Why? Because you cannot count or measure the follicles on transabdominal sonography because the resolution of transabdominal sonography is not good. Okay? So that is something which you should know. Now when to start treatment? We know the definition. Within 1 year, you should start treatment of infertility. We know the definition which says that if the age is more than 35, you should start treatment within 6 months. But I would say that if the patient is a young girl, say 28 years, and she is known case of PCO, you can start treatment immediately. So this is the case of Yasmin. Yasmin is 25 years. She is married since 3 months. Her BMI is 30, breast to ratio 1.2. She belongs to phenotype A. On Yasmin, you know what is Yasmin? OCD. So Yasmin is on Yasmin. Since last 2 years, she is eager to conceive. What is your approach? How do you start the treatment? You should know the approach, case-wise approach. In case of Yasmin, the first thing which you have to do is stop her OCS and do investigations after 3 months. I have already told you because you have to wait for 3 months. So, हे 3 महिने तुम्ही काय कराल? तुम्ही पेशंटला म्हणाला तू घरी जा आता आपण 3 महिन्यानंतर भेटू नाही. Utilize this time, utilize this 3 months period for weight reduction, for lifestyle modification. Ask her to reduce weight so that whenever she comes back after 3 months and when you do investigation, she is all set and she may spontaneously start ovulating. Because if the weight reduction is achieved, then she may start ovulating also. So, and Yasmin was investigated 4 years back. So we don't have her reports available. Now you have to investigate her and she wants to conceive. So what are the investigations you will do? We have discussed about the testosterone, we have discussed about free androgen index. All these investigations were related to androgen excess. They have nothing to do with infertility. Now you have to investigate her for the infertility. And here the investigations are day 2 FSH, day 2 LH, prolactin, free T4 and TSH. No LH-FSH ratio. LH-FSH ratio is now past. It is gone. Bye LH-FSH ratio. LH-FSH ratio कोई नहीं करता. But you have to do LH and also you have to see the FSH. Then you have to do something for metabolic problems also. What are the investigations you will do for metabolic problem? GTT you will do. You will do blood sugar fasting. You will do serum insulin. Serum insulin you should do. Actually, the guidelines say that fasting insulin should not be done as an investigation for the metabolic disorder. So, what are the investigations? OGTT, HbA1c, and fasting sugar, along with lipid profile, because this lipidemia is very common. Metabolic disorders are very common in PCO, and AMH. I love AMH. I simply love AMH. I cannot imagine life without AMH, and I would suggest all young girls sitting over here to get their AMH done. This is the message which I spread to the society wherever I meet young girls. I ask them to get their AMH done and then decide about your marriage and family after your AMH report. So AMH will give you an idea about your ovarian reserve. This AMH 2018 में जो गाइडेंस थे उसमें उन्होंने बोला था कि it should not be used, and they have said that there is an emerging evidence that this is a good test but it should not be done. लेकिन एक साल बाद क्या हुआ देखो, एक साल बाद, so this is the evidence, एक साल बाद 2019 HTA guidelines for ovarian stimulation came and they have said that AMH alone is reliable, AFC alone is reliable, FSH alone is not sufficiently reliable, inhibin B not a predictor, age alone is not reliable, BMI not a predictor, and progesterone not recommended. So the total change in the guidelines, and now it is said that दो हीरो कौन है अभी आज के तारीख में, AMH and AFC. These are the two investigations and a strong recommendation 2019 which says that for predicting high and poor response both or to ovarian stimulation, use of either AFC or AMH is recommended over the other ovarian reserve testing. Very clear? So these are the two things which are important. These we have already discussed, but I must say that the Yasmin belongs to Indian ethnicity, and here you must try to get a family history also, and you must do her GTT also. And the recommendation says that if BMI is more than 23, in Asians 23, you should do OGTT, you should do HbA1c, you should do lipid profile, and you should rule out diabetes also. And as I told you, bye-bye fasting insulin. Now, PCO workup is done. We are all set for the treatment. How do you start the treatment? You have to rule out other factors also. फक्त एकाच गोष्टीवर फोकस करून चालणार नाही. You have to think of the other factors also, male factor also, other factors also. And what about tubal patency? The guidelines say that the risk, benefit, cost and timing of the tubal patency should be discussed on an individual basis. Means what? You need not do tubal patency in case of Yasmin. We are discussing Yasmin. Yasmin is a case where there is no history of PID, where there is no genetic tuberculosis. You don't think that there is a doughy feel on abdomen. You don't think that there is a white discharge PD. There is no history of abortions, no history of D&E. So no interference. So no chance of infection. So you can actually postpone tubal patency and start ovulation induction immediately. That is what the guidelines say. Now, as we have discussed lifestyle modification, 5% weight reduction is something which is important, and here comes the smart approach by smart doctors like you. What is smart approach? Specific, measurable, achievable, realistic and timely. एक एक शब्द देखो और उसका अर्थ समझ लो. Specific, measurable, achievable, realistic and timely. Because if you ask somebody to reduce her weight by 30 kgs, she will get rebound weight gain by 50 kgs. So that is why you should ask them to reduce weight by only 5 to 10%, so that they can achieve this slowly and steadily. And the guidelines also say that use iWatch or Apple Watch or smartwatch, use various apps to track your physical activity. So they have added this. Use of smartwatches is added in the recommendations and guidelines. You should use these apps so that you know actually how much exercise you are doing. Now everything is set for ovulation induction. The first thing we do is ovulation induction. And ovulation induction is the first treatment of PCO, and this is the algorithm which we are going to follow in the next 25 minutes or 20 minutes, whatever. Ashish, you will tell me once my time is over. CC and letrozole. These are the two drugs which are important. Here, actually, induction started with CC. Clomiphene citrate is the age-old drug. It is available since 1960 and it is time tested. But the problem is nobody nowadays respects age unless it is bottled and distilled. Only age is respected when it is bottled and distilled. Old wine को जो respect मिलती है वो old आदमी को नहीं मिलती. ये problem है और इसीलिए now the thing which has come up is letrozole, and letrozole is becoming very popular these days. So whenever we get PCO, you should start induction with letrozole. And this letrozole is the drug of choice, I tell you that. But remember friends, whenever we are discussing about the no response to CC, you call it as CC resistant cases. This is not only CC but also letrozole. Because CC resistance है, जो terminology ये सबके दिमाग में बैठी हुई है. But now the CC is replaced by letrozole. So whenever we talk of CC resistance, it is letrozole resistant as well. We all should. This is the question which you will get in the exams. The tragedy with CC. CC, if you give 100% CC, 75% will ovulate, 25% will not ovulate at all. They are called as CC resistant cases. And 75% will ovulate, but only 35 to 40% will conceive, and 35% 40% will not conceive. They are called as CC failure. फेल कौन होता है? जो एग्जाम में बैठता है वो फेल होता है, और जो एग्जाम में बैठता ही नहीं वो ये 25% है जिसको तुम बोलोगे CC resistant cases. So CC resistant is no ovulation at all. CC failure is ovulation taking place but the conception. So the conception rate with CC is low. That is a tragedy with CC. And it is more common with overt PCO with very high image and obesity and high androgen. The resistance is problem. And here you should know that the starting dose of CC is low, written in books that it is 50 to 250 milligram. The ideal dose is 100 milligram. And most of the people they start with 100 milligram because less than 50% patient they respond to 50. So don't start with 50. That is called a cutting corner regime where you start with 100 and usually practically do not go beyond 150 because there is no point in giving 250 though it is written in ancient books. There is no advantage in giving very high dose of CC because it will lead to ovarian hyperstimulatio syndrome. So only 50 to 100 to 150. And if there is no response in 6 cycles अब बहुत ज़्यादा हो गया आजकल तो nobody waits for 3-6 cycles also. And if the endometrium is persistently thin, because endometrium is something which you have to focus. And the problem is CC is the anti-estrogenic property of strobic acid which leads to thin endometrium. And therefore, if the endometrium is less than 7 mm, you must move on. And now comes the endorsement by the 2000